thank you so much, Mr. Gary Taubes.
Thank you, Gary. Thank you. I want to say what Sam's done here is amazing. So from the perspective of coming from 6,000 miles away, however far it is, it's really terrific to see sort of how far everything has gone in this group, and Sam's an extraordinary guy. So anyway, my job, starting now, is to give you about 227 years of diabetes history in 45 minutes. I have no idea if I can do it, so I'm going to talk fast, not because I'm trying to sell you something, because we have a lot of ground. If you notice the slides, there are a lot of slides. David's just been through this, so we don't really have to cover the question always when I give talks, why bother rethinking diabetes? And because we have something of a medical tragedy / catastrophe on our hands, and the numbers are unbelievable. So yeah, the main issue that I want to address today is, despite the numbers, 4 million people in the UK with diabetes, another 850,000 who don't know they have it, 1 in 10 healthcare dollars. In the US, that's 1 in 4 healthcare dollars has gone to treating diabetes and its complications. The thing that's such a sort of incomprehensible phenomena is that today diabetes is still considered a chronic progressive disorder. Okay, so this means in effect that they'll only get worse once a diagnosis is given. And this was a 2017 American Diabetes Association publication where they said the most frustrating barrier at optimizing diabetes management is the frequent occurrence of what they called clinical inertia. So despite clear evidence from multiple studies, healthcare providers fail to fully appreciate that type 2 diabetes is a progressive disease associated with ongoing beta cell failure, and as a consequence, we can safely predict that the majority of patients, glycemic control will deteriorate with time. So part of what I'm going to be doing in this history is discussing how that happened. And what I want you to keep in mind while we're doing it is this very simple fact. Okay, I wrote this entire book, Rethinking Diabetes, based on 25 years of research and 4 other books, and after I write the book, somebody points out to me that there's basically 2 levers you can pull to control blood sugar. These are my levers. Diet or drugs. You can control blood sugar with diet, you can control blood sugar with drugs. For the past 102 years, we've been doing it primarily with drugs. So that's what we're going to be discussing. How do we get here? A very short history of diabetes and diet. And the place where everything shifted, I'm going to go back in steps in time, was 1971, when the American Diabetes Association gave its first sort of full principles of nutrition and dietary recommendations and said there's no longer any need to restrict disproportionately the intake of carbohydrates in the diet of most diabetic patients. So in this document, the American Diabetes Association specified that patients with diabetes, which is a disorder of carbohydrate intolerance, you can't metabolize the carbohydrates in the diet safely without pharmaceuticals, should get over 50% of their calories from the carbohydrates that they can't metabolize safely. What happened briefly at this point is we had come to conclude that dietary fat caused heart disease, so we should all be on low-fat diets. The American Heart Association had embraced it. The American Diabetes Association followed. And there's one thing to keep in mind when I say the ADA, this was basically the work of one man, a guy named Ed Bierman at the University of Washington. And when you study the history of these diseases, one of the things you realize is how influential a single individual can be. This is true of all sciences, by the way. When we speak about physics, you know, it's like Einstein was a very influential guy. The problem is sometimes the very influential guys were right, and sometimes they were wrong. But there's always an influential guy. This was a New York Times headline, major medical group in a major change urges a normal carbohydrate diet for diabetes. Okay, the fundamental patient is suffering from disease characterized first and foremost by the inability to safely metabolize the carb content and should be told to eat 50% of their calories from carbs. So how did we get here? And this is a longer short history of diabetes and diet. And there's a few things I want you to keep in mind as we go, because these were part of my learning experience. The first is a concept that was put forth by the cognitive Nobel laureate Richard Kahneman. What you see is all there is. So if you want to understand why people make decisions, it helps to understand what they're seeing. And when we go back in history, and especially now with the internet and all these article repositories, like you can basically see everything that people were seeing at the time they were making these decisions. And one of the things you realize in this history is that they're making decisions based on very limited information. So for instance, in 1921, we conclude that diabetes is a disease of insulin dysregulation, but circulating levels of insulin and the hormone glucagon could not be measured for another 40 years. So all of diabetes was seen as an insulin deficiency disease, a pancreatic insulin deficiency disease, even though they basically had no way to measure insulin. They had no way from 1921 until 1960. And diabetes is a disease of blood sugar dysregulation, but they had no way, nobody was measuring blood sugar in their patients effectively until 1970, and we'll get there. So as we go through the history, these are the questions to keep in mind. Does controlling blood sugar prevent diabetic complications? That's what the medical research establishment was obsessed with learning. If we can control blood sugar, can we control complications? And if so, is it better to do it by drugs or diet or both? And if diet, of course, which diet? Okay, so now I'm going to go through the history in eras, and I'm going to do this because the dominant force in diabetes thinking in the first half of the 20th century was an American named Elliot Joslin, who founded the first dedicated diabetes clinic in the US in 1898 in Boston. It's now 126 years later become the Joslin Diabetes Research Center at Harvard. And Joslin wrote the first, he had more patients than anyone else. So by 1916, he could write a textbook based on 1,000 patients. And in 1917, he did an edition with 1,300. And in 1921, it was 3,000 patients. And this textbook is still being published today. And so Joslin had outsized, basically what he thought determined what everybody else thought. And Joslin liked to break the diabetes history into eras. And the first one was the Rollo era, which was 1797 to 1880s. And Rollo was a British researcher, a British doctor working for the army in 1797 when he saw a patient with diabetes, a Colonel Meredith, and he put Colonel Meredith, the way he knew he had diabetes, he was hungry all the time, he was thirsty all the time, he had lost a lot of weight, he was peeing profusely, and his urine tasted like sugar, because back in that era, one of the ways doctors did diagnosis was to have their assistant taste the urine. If you had an assistant. Anyway, he decides if the urine tastes like sugar, maybe this guy can't metabolize carbohydrates, so therefore we're going to put him on a carbohydrate-free diet. He didn't think in terms of carbohydrates. It was the animal diet, and Meredith got better. So fatty animal products, actually originally it was rancid fatty animal products and green vegetables, and then eventually Rollo dropped the rancid part. Meredith got better. He was like the first patient who ever got cured. He died around 12 years later. I mean, this guy had type 2 diabetes, lost a lot of weight, looked like type 1 diabetes. Rollo cured him. He sees another patient, an army general, who gets better until he falls off the diet and then dies. And Rollo publishes this pamphlet, and he circulates the pamphlet around the UK, and he says to people, look, I think I cured a case of diabetes with this diet. Maybe you can try it. This is with medicine preclinical trials. And doctors did, and they wrote into Rollo, and he published consecutive editions of the pamphlet, and with each edition, this thing sort of dug in. It worked. It kept the disease under control, and through the 19th century, this animal diet became the standard of care. Okay, this is Frederick Pavey, who was a leading diabetes researcher in the UK in the 1860s. He said there can be no reason against a strictly animal regimen being adequate to all the physiological requirements of the diabetic, and I believe if preserved then for a short time, it would come to be taken without giving rise to any feelings of material privation. Indeed, I've been told by patients whom I have restricted to animal food that after a little while they have experienced no desire to take any other. Okay, I'm sure we've all said things like that to our allies and patients and friends, today, 150 years later. So this was a standard of care, not just in the UK, but in France and Germany and Italy. And by I mean the standard of care, I mean every leading diabetes authority. And there weren't a lot of them because there weren't a lot of diabetics. It was a very rare condition. But they all proposed this diet. They believed they could keep type 2 diabetes under control if the patients didn't eat starches and sweets. And type 1 diabetes, which requires insulin, they could at least slow down the eventual demise of the patient. By the 1880s, we moved to the Naumann era. Bernard Naumann was a leading German authority. When a patient appeared in the physician's office back then with diabetes, they usually did so after they lost a lot of weight. So the doctors wanted to give them as many calories as humanly possible to fatten them back up. That made sense. And if you couldn't feed them carbohydrates, you fed them fat. Okay, this is going to sound familiar. So now we get basically, as Jocelyn described, that a diabetic diet is really an ordinary diet in which the carbs are replaced by fat. It's necessary for the diabetic individual to eat 2 to 5 times as much fat as usual. Comparatively little of this fat can be taken as meat, and this necessitates the use of much cream, butter, and oil. So basically, by the late 1900s, a purely ketogenic diet was the standard of care. Jocelyn, one of the reasons he was so interested in diabetes is because his mother and his aunt had diabetes. His aunt died from it. His mother, he went to Germany to learn from Naumann. He got his mother on this diet. His mother lived longer than anyone else in the family. He had become sort of convinced it worked until the next era came around, which was the Allen era, and Allen was a Harvard compatriot of Jocelyn, and he did hundreds of animal experiments, came to all the wrong conclusions, and decided that the best way to treat diabetic patients was to starve them, because if you starved patients with type 1 diabetes, who, by the way, the symptoms of uncontrolled type 1 diabetes not only include significant weight loss, but voracious hunger. Now you don't feed them at all, or you feed them very little. You could control the symptoms of the disease and keep them alive a little more. So Allen wrote this book, The Treatment of Diabetes Mellitus. Allen wrote, this is 1916, Jocelyn's textbook first comes out, and Jocelyn becomes a fan of Allen's fasting and diabetes. And the way Allen said it, he said, previously the attempt has been to maintain these patients at the highest possible level of weight and nutrition with the idea of helping them to withstand a wasting disease. The present idea is the opposite to this, namely that the reduction of weight is in itself beneficial to the diabetic condition and serves to spare the weakened function and increase tolerance. Wait, we're going backwards, forwards. It says this measure, like the others, is carried to any point that may be necessary in any particular instance, and any point was to starve these children. And the patients of the era who were kept alive by this diet horrified physicians from other countries. Van Noorden was the leading German diabetologist after Naumann. And as Jocelyn described 50 years later, he said he came to Boston and he just shuddered to see the kind of patients who were walking around Jocelyn's clinic. And in fact, by 1946, when Jocelyn said this, it was right after World War II. And the patients had, the doctors at this conference had just, for the first time, really been seeing photos of the survivors of the Nazi concentration camps, and they all commented that these kids looked like them. Jocelyn said that prolonged fasting has changed the treatment of diabetic patients from a duty to a pleasure. So if you can't feed them carbs and you're going to fast them, you also can't feed them fat. So basically it was a semi-starvation diet, restricted in carbohydrates and restricted in fat. And Jocelyn became, because of that, started to believe that it was dietary fat that actually caused the complications they saw in their patients. And then in 1920, what should begin was the Newburgh-Marsh-Petran era, but it didn't. Okay? So Newburgh-Marsh were University of Michigan physicians who decided they really couldn't starve their patients because if they starved them, they weakened their facilities that way. They could die very easily from colds or infections, but they could keep them alive, and they just went back to this high-fat diet, but they eased them onto the high-fat diet. and they said they could give them significant amount of calories, and their patients did wonderfully. And they published a series of 3 papers in Archives of Internal Medicine and said, look, people thrive on this, high-fat, low-carb diet. See who is, and then in Sweden, Petran published the same. Carl Petran had been a student of Naumann and Van Noorden in Germany, went back to Sweden, put people on very high-fat diets. One of the German doctors said these diets are unbelievable. The patients did really well. Even after insulin was discovered, the patients still did really well. And yet, he said he couldn't really imagine Germans doing it because you'd see Swedes living on cucumbers and butter. And he couldn't imagine German patients living on cucumbers and butter. He also said he couldn't imagine German patients being semi-starved like Jocelyn was doing with the Americans. So everything became sort of balkanized as different countries went different ways. So Petran didn't even allow bacon because of the protein content, and reported that his patients thrived. And his first report of his work was in 1923, after it was transcribed. But by that point, Fred Allen and Jocelyn were talking about how these diets didn't work for them. They were willing to try these high-fat diets, they said, but they failed in their clinics. Jocelyn said it when Newberg and Marsh presented their evidence at a conference in 1921. He said, what shall I do with 2 boys with diabetes beginning at the age of 12, but now at the end of 3 or 4 years of treatment by the old method? Shall I put these boys on lower protein and push up their fat? Or shall I continue by those methods which have helped them for these 3 years? With these cases, I shall not adopt new methods. We must be positive not to lose the advantages gained. So even back then, you could see the resistance to anything new. Once somebody became wedded to an idea, a way of treating patients, Jocelyn was blaming it on his patients, but the fact is you don't want to admit that there might have been a better way to do it. The Banting era begins in 1921, 1922 with the discovery of insulin. Okay, so just as we finally have a discussion about whether a high-fat diet can really help patients pushed by Newberg, Marsh, and Petran, insulin is discovered. And insulin saves lives. Insulin is a wonder drug, okay? And these are the kinds of photos you saw in the early papers where these emaciated children would fatten up and get healthy in days of starting on insulin therapy, okay? So I have to remind you, back then in the early 1920s, they didn't differentiate between type 1 and type 2 diabetes. Okay, patients with type 2, they knew there was a form that hit older, heavier patients, and that was tended to be chronic, and an acute form that hit children. But by the time the older, heavier patients went to see a doctor, because they weren't getting their blood tested regularly, they weren't going for checkups regularly, they would go to the doctor after they lost a lot of weight, and had many of the symptoms appeared very similar to patients with type 1. So when insulin is discovered, everybody goes on insulin. Not just type 1 patients, for whom it's a lifesaver, but type 2 patients as well. So 90% of the patients are going on diet, or 90% who may not need it. And then there are all kinds of complications that come with insulin. So until insulin comes along, you're either starving your patients or you're giving them very low-carb, high-fat diets. Insulin creates the condition of hypoglycemia, low blood sugar. It does not exist before insulin therapy, more or less. There are caveats to that statement, but for the most part, hypoglycemia is a new creation and patients can die from it. And in the era, they refer to insulin shock or insulin reactions. That's what hypoglycemia is, and the symptoms are very clear. In fact, in Toronto, Banting and his colleagues knew that their insulin was lowering blood sugar because they saw these symptoms in rabbits. An overdose of insulin caused a warning train of symptoms, beginning with nervousness and extreme hunger as the blood sugar drops, progressing to sweating and tremor, subconscious or evident. So diabetes can kill slowly in type 2. It can kill relatively quickly in type 1. Insulin can kill overnight. Okay, this is an incredibly powerful drug. And so how do you treat hypoglycemia? Well, you give them carbohydrates. right? Make them drink orange juice or sweets. And the way to balance out hypoglycemia, because it's almost impossible to figure out how to dose this drug properly. It's so powerful. And in my book, I discuss there are wonderful discussions about all the complications, because everybody's different. And not only is everybody different, so you have to discover a dosing regimen for everyone, they're different from day to day and month to month and hour and hour. And there are patients that they're giving insulin at like 9 in the morning who are dying from hypoglycemia at 4 in the morning, 15 hours later, even though the insulin can't possibly last that long in their circulation. And they're working this out as they go along. And the easiest way to do it is to give them carbs. So you go from giving no carbs to feeding them ever more liberal carbohydrate diets. Okay, and the diets get more and more liberal through the 1920s because it's just easier, particularly with children. So you have a 9-year-old who's diagnosed with type 1 diabetes. He's got this terrible disease. It's going to shorten his life or her life significantly. Do you really want to tell this kid that he can never have an ice cream cone again? Or he can never have a birthday cake again? Or he can't eat what his siblings eat ever again? So instead, you let them eat what they want, and you give them the insulin. And the kids feel better. And then as soon as it starts working for kids, they start doing it for adults also. And the diets become ever more liberal, and the insulin doses get ever higher. Okay. And here you see just various, these are different, Sansum opened a clinic in Santa Barbara that 100 years later is a Sansum clinic. On such diets, the patients are freed from the slightest traces of the acetone type of acidosis because they were afraid of these kids dying from diabetic ketoacidosis. They like the carbs-rich diets. They lose their cravings for forbidden foods, especially the carbs. So if you feed them carbohydrates, they lose the craving for carbohydrates, which you don't want them to have, because if they have the cravings, they'll eat the carbohydrates. Interesting logic. About 40% more insulin is required in the beginning, but it's not difficult to render such patients sugar-free and their blood sugar normal. So the way they're testing whether or not the disease is under control is by measuring blood sugar. Urine sugar. So if you got sugar in the urine, your disease is out of control. You have no idea how that reflects the sort of hour-to-hour variations in blood sugar as we pay attention to today. But that was their diagnostic criteria. So we get ever higher doses of insulin as we use more and more carbohydrates in the diet, and you kill off the low-carb, high-fat diets entirely. In part, this was Jocelyn's work, because Jocelyn came to believe that the high-fat nature of the diets was the reason for all the diabetic complications, the heart disease, the retinopathies, the neuropathies that were killing their patients. So Jocelyn had various arguments against high-fat diets all the way along. One of them was that the goal, if a diabetic patient can't metabolize carbohydrates, the goal of therapy should be to get him to metabolize as much carbohydrates as possible. And if you're not feeding him carbohydrates, he'll never regain that facility. It kind of makes sense. He said, like, if somebody breaks their arm, the goal is to let the arm heal so that they could use their arm as much as possible. You don't tell them never use your arm again. And that was the kind of argument that they made. So as long as you think that an improvement in tolerance for carbs is a cardinal principle, you have to feed as much carbohydrates as insulin allowed that to happen. And then the last complication of the Banting era was a tidal wave of diabetic complications. So until spring 1922, patients with type 1 diabetes didn't live long enough to see the long-term complications of the disease. But now you're keeping these patients alive. You're saving their lives. So, excuse me for laughing. I was just looking at the time and thinking, it's never going to work. Sorry, Sam. Got a kid who's diagnosed with type 1 diabetes when he's 9 years old, or she's 9 years old. Without insulin, she's dead by the time she's 10 or 11. With insulin, you save her life. But now, 10, 15 years later, suddenly you start seeing the long-term complications. They assume it's the long-term complications of living with diabetes and poorly controlled blood sugar. It's not being controlled well enough. But suddenly these patients are dying relatively quickly, is their whole body sort of, arteriosclerosis blossoms throughout their bodies, the nerve damage, amputations, blindness, heart disease, strokes, tuberculosis is killing them. And they turn diabetes into a chronic disorder, and now you're seeing the chronic complications that we're so familiar with today. And they misinterpret what these chronic complications are from because they assume it's uncontrolled blood sugar. But all they know at the time, again, this is a what you see is all there is phenomena, all they know is that they're keeping these patients alive on high carbohydrate diets with large doses of insulin. They have no other perspective. So they assume they're not using insulin intensely enough or thoughtfully enough, or the patients aren't taking their insulin doses regularly enough, and so the uncontrolled blood sugar is causing these complications. But it could be the diet, and it could be the insulin itself that's making all of this worse. But through the 1930s, this is what they come to grips with. In 1937, they get a new version of insulin comes along, long-lasting protamine zinc insulin. So they have yet a better drug. And in the 1940s, they get, okay, we're going to skip that. We've been through this. Boom. Maybe we won't skip it. Okay. 1960s. So World War II happens. 1947, the introduction of the first oral hypoglycemic agents, a drug called tolbutamide. Okay, so finally, this was the holy grail of insulin therapy, or of diabetes, a means to control blood sugar without having to take an injection. Okay, now you can do it with oral pills, and there's a congressman in Ohio whose daughter is diagnosed with diabetes, and she's put on tolbutamide, and the congressman asks a physician, a diabetes specialist at the Cleveland Clinic, if the tolbutamide will make her live longer, and the doctor says, we don't know. So they decide to do a clinical trial, and the congressman helps them get funding, and the first clinical trial, which I hope I'm going to get to, I'm skipping ahead. Okay, so let's skip back. We're going to hold tolbutamide here for a second. 1960, Yalow and Burson discovered what's called the radioimmunoassay. Okay, so from 1921, when insulin is discovered, it confirms this thinking that insulin is a pancreatic deficiency disease. Diabetes is you get insulin from the pancreas. When the pancreas is injured, you have diabetes. So all diabetes is an insulin deficiency disease. We treat it by giving insulin. 1960, we finally have a way to measure hormones in the bloodstream, courtesy of Rosalind Yalow and Salomon Burson. And from the very first paper, it's clear that patients with type 2 diabetes do not have an insulin deficiency disease. They have a disease of insulin excess, the exact opposite. But we are still giving them insulin to treat it. So every other hormonal endocrine disorder, if you've got high levels of the hormone, you try to lower them. If you have low levels, you try to raise them. With diabetes, 90% of the patients have high levels of insulin. We are going to treat it by giving them ever more insulin. This was one of the fascinating aspects of this history is that no matter what they learned about the disease, it didn't change therapy, because the therapy was locked in by the way the doctors thought, and even if they changed how they thought about the disease, they couldn't change how they treated their patients. Okay, so here's the first clinical trial. I told you about tolbutamide, the university group diabetes program. It starts around 1960, and they compare, this may have been the only trial ever done that compared not just tolbutamide, this oral hypoglycemic agent, but insulin itself to diet alone. This may have been the only time they ever compared insulin to diet. And the result was, in the maturity onset diabetic, neither insulin nor oral hypoglycemic agents gave greater protection against these complications than diet alone. Not even the insulin helped. This was a huge controversy when it came out in 1971. It was leaked to the Wall Street Journal. Before the publications, the diabetes community went crazy, and they basically decided that they were going to ignore it because they couldn't deal with it. But in the process, Dietary management deserves greater emphasis in the management of this type of diabetic. This is maturity onset is type 2. And so this leads to the ADA special report also, because they're responding. We have to do something for these patients. It's conceivable that neither oral hypoglycemics or insulin extend their lives. We know that dietary fat causes heart disease in theory. At least we think we know it. We know that saturated fat's a problem. We're going to put every diabetic patient, all of them at high risk of having heart attacks, on low-fat, high-carb diets. And so we're going to sacrifice blood sugar control. They didn't think of it this way. I do. They're going to sacrifice blood sugar control for cholesterol control. We've been doing that since 1971. Okay, the Bernstein era. I mentioned nobody could measure blood sugar. Prior to 1970, if a patient wanted to get a patient diagnosed with diabetes would go to see the doctor. The doctor would take a blood test. 2 weeks later, you'd get a report of the blood sugar, which would help them diagnose whether or not the diabetes was under control, because the patient will have changed the way they ate as they're going into the doctor's appointment. This isn't going to reflect their habitual diet anyway. There's no idea to know what's happening in the blood in these patients, but we're going to treat them as we've been treating them along, just trying to lower blood sugar and give them insulin. Richard Bernstein, Bernstein Diabetes Solution, is patient number 1, the first person ever to get a hold of a blood sugar monitor, which he does. So he's diagnosed at 12 with type 1 diabetes in 1946. He goes to Columbia University, he gets a degree in engineering, he gets a job in business, he's working through the 1960s, he has a few kids. The diabetic complications are killing him, even though he's doing everything he's being told to do, and he sees an advertisement for this blood sugar monitor, which was being sold to hospitals, because if somebody checked in emergency rooms, if somebody checked into an emergency room on a weekend night, was brought in unconscious, you had to know whether they had passed out from alcohol or in a diabetic coma or both. So you needed to be able to measure their blood sugar. So these were being sold to emergency rooms. Bernstein's wife was a physician. She got a prescription. He got one from the company that made them and began working to measure his blood sugar as regularly as he can, 5 to 8 times a day. And over the course of 3 years, some fits and starts, working with the chief salesman of the company, he realizes that the only way he could keep his blood sugar under control, and he could keep it in perfect control, normal blood sugar, is if he doesn't eat carbohydrates. If you eat a piece of bread, you can't do it. You can't plan for it. You can't dose your insulin for it. The only way to do it is not to eat the carbs. He comes up with this theory that he calls the theory of small numbers, which is basically the way engineers and physicists think, which is you could control this kind of chaotic system if you minimize the inputs. So minimize the carbohydrates that you need insulin to treat, and that way you could minimize the insulin therapy by doing it. He starts a revolution. Bernstein is into networking, loves to talk about networking. Bernstein is turning 90, by the way, any day. So he networks. He's in New York, where the leading diabetes researchers in the world are in New York City at the time at Rockefeller University and State University of New York downstate. And he gets connected with these people. And he says to them, look, I have normal blood sugar. I got type 1 diabetes and I can keep my blood sugar normal. And they say, that's crazy. Nobody can do that. And he says, let me show you. And he proves it to them. And they start trying to do it with their patients. And they launch a series of small clinical trials with their patients. This is at Rockefeller, SUNY downstate, Cornell. And they demonstrate that they could get remarkable blood sugar control. The early patients in these trials are often pregnant women, because women with pregnancy, diabetes, and diabetic women, pregnancy even in the 1970s was a nightmare, often ended awfully for these patients. So they were very motivated to do anything they could to have a healthy pregnancy and a healthy baby. A whole series of papers are published, which Bernstein is an author, a co-author. Bernstein, they're all here. And by the 1980s, Bernstein's work and all these New York physicians and some UK physicians prompt the second biggest diabetes trial, the Diabetes Complications and Control trial. And what's interesting is, so Bernstein's method is measure your blood sugar, minimize your carbohydrate intake. He wasn't a keto fan, which back then meant being an Atkins fan, because he believed the LDL cholesterol saturated fat story, but he minimized carbs and replaced those calories with protein. Then you had to dose the insulin for the protein, and then you could minimize insulin. And at the same period of time, in the late 70s, the insulin pumps came in, and hemoglobin A1C came in as a measurement from these people Bernstein was working with at Rockefeller. And so they initiate this trial that Bernstein spurs, but they refuse to test his diet because by this time the ADA is recommending a low-fat, high-carb diet. So an American trial has to follow ADA guidelines. So it becomes a trial of insulin therapy, standard therapy versus very tight control of type 1 diabetes, and the patients do moderately better. Their A1C stays high, their average blood sugar stays relatively high, but it does lower their complications, and this is considered, as the newspapers put it, the most important discovery for diabetics since insulin. So type 1 diabetes, you can do better with intensive therapy and intensive blood sugar control. And when the New York Times, in doing so, I mean, there are trade-offs, by the way. Patients gain a lot of weight. The more insulin people use, the fatter they get. And they have more hypoglycemic episodes. And the risk of dying from hypoglycemia is higher, but you can minimize complications. And when the article comes out, Bernstein is vindicated. He's a diabetes expert, but he tells the New York Times those in the study followed some version of a high-carb diet and used large doses of insulin. Come back. Well, our regimen for type 1 insulin-dependent diabetes is for a very low-carb diet and very small doses of insulin, because insulin does not work as fast as carbs in affecting blood sugar, and when you get large amounts of both, you get blood. So insulin, Bernstein almost single-handedly motivates this trial, but they only test drugs and devices and A1C. They will not test his diet. That is a common theme throughout this whole area. We do not test diet because the diet is set by what the ADA recommends, and the ADA recommends a low-carb, low-fat, high-carb diet because we want to keep cholesterol low, even if it makes blood sugar high. This is the third major trial of this era in which they demonstrated that this is a chronic progressive disease. I'll skip through it. Fourth, fifth, and sixth clinical trials of this era. Now they're testing intensive insulin therapy for type 2 diabetes. We've demonstrated that we can minimize complications for type 1. Let's demonstrate that if we tighten up blood sugar control with intensive insulin therapy in type 2, we can minimize complications, and all these trials fail. Here's intensive therapy. This is patients with events, and here's standard therapy, and you actually get more events with intensive therapy than standard therapy. This is 3 different trials. The finding of higher mortality in the intensive therapy group led to a discontinuation after a mean of 3.5 years. There were no significant effects of the type of glucose control on major vascular events. Intensive glucose control in patients with poorly controlled type 2 diabetes had no significant effect on the rate. So 2007, 2008, we finally test very intensive insulin therapy on type 2. Remember, the only time they tested insulin therapy against diet, the insulin therapy didn't do anything. That was the University Group Diabetes Program in 1960. When they test intensive insulin therapy against standard insulin therapy, that doesn't do anything. It has 0 effect on therapy. Okay? The last major clinical trials look ahead. Throughout this period, one of the bedrock beliefs of diabetes and obesity treatment is that diabetes is made worse by obesity. And if you could get people to lose weight, you will prevent the complications of the disease. Look ahead is a $200 million trial to demonstrate this. 5,000 patients randomized to intensive lifestyle intervention. They follow it for 13 years, and it ends up failing. They actually get people to lose weight. They get them to work out. Their waist circumference comes down. They even improve their A1C. And it has zero effect on complications, okay? Bedrock belief since before Jocelyn is tested rigorously and it fails the trial for anyone who cares. They also got them to lower their cholesterol in the intensive therapy group, and that had no benefits. We have to have an adult conversation about this. This was a negative result. This was the leading Harvard diabetologist, David Nathan, telling the New York Times when this study was published in 2013. Okay, so all of their bedrock beliefs have failed. The one thing they've never tested along the way are diet, because they've always assumed that patients with diabetes should eat pretty much the same diet anyone eats, just space out your carbohydrates to make it easier to dose insulin. So pre-1921, diet is a therapy. Post-1921 with insulin, diet is an adjunct of diabetes therapy, and every major diabetes document will say that diet is a bedrock cornerstone of diabetes therapy, but they will also imply that nobody sticks with the diets. So what these trials all had in common, the ADA-AHA dietary recommendations, low-fat diets. And finally, 80 years after Newberg and Marsh and Petran come and go, the obesity epidemic sets in. And physicians, mostly in the US, in the late 1990s, confronted with, we've all been through this, waiting rooms with ever more and more obese patients, start having the patients go on the Atkins diet, which is what keto was called when I was growing up. Minor variations. And these patients go on the Atkins diet and they get much better. This is the common phenomenon with virtually everyone in the field. It's like either you do it yourself or one of your patients does it, they get better. In this case, one of the first patients was Eric Westman at Duke University in North Carolina has a patient who goes on Atkins against his will. Comes back, has lost 25 pounds, his heart disease risk factors have gotten better, and Eric, rather than seeing the truth, stumbling over it and walking on, says, this is fascinating, maybe I should study this. He actually goes to Atkins to get money to run a clinical trial, and beginning with Eric Westman, they start running clinical trials in the US on effect on the Atkins diet. This is what got me into it as a journalist when these trials were done and hadn't been published yet. And one of the trials at the Philadelphia VA hospital on obese and very obese patients run by Dr. Samaha and Linda Stern, they didn't want to exclude patients with diabetes because they figured that most of their obese patients, especially in VA hospitals, had diabetes, so they would use this diet for them too, and they did, and this was the first sort of test of the Newberg-Marsh-Petran diet 80 years later, and it was very successful. Okay, severely obese subjects with a high prevalence of diabetes or MET syndrome lost more weight during 6 months on a carb-restricted diet than on a calorie and fat. They had relatively improved, everything we've seen ever since. What is this trial? Oh, Verta Health, excuse me. 2015 or so, Verta Health comes along. Steve Finney and Jeff Volek are obsessed. They've been studying ketogenic diets. They decide they're the best way to treat type 2 diabetes. They get together with Sami Inkinen. They start Verta Health. Verta Health runs this non-randomized clinical trial with the late, great Sarah Hallberg as the principal investigator. And they put patients either on standard of care at the University of Indiana Health Service or at on nutritional ketosis with smartphones and health coaches and telemedicine, and the patients do wonderfully, just as they did in the 19th century. Basically, this diet goes into remission. David Unwin, of course, you can demonstrate it in the clinical trials. Verta demonstrates the remarkable ability of these diets to put diabetes into remission. It works in clinics too, and David Unwin major force pushing it here, demonstrating that if you just take this thinking, you can apply it to your patients and your patients will get better. They have a disorder of carbohydrate intolerance. I don't know why that covers up like that. Hypothesis, type 2 diabetes is only a chronic progressive disease, in the context of a carbohydrate-rich diet. So this is what you end up with. If you just look at the data in this century and a half of clinical trials and failed clinical trials without any preconceptions whatsoever, this disorder is a chronic progressive disease in a carbohydrate-rich environment. Absent the carbohydrates, people don't manifest symptoms of the disease, and they thrive. I mean, it makes perfect sense. I have a corn allergy. If I don't eat corn, I don't get gastrointestinal problems. If you have a carbohydrate intolerance disorder and you don't eat carbohydrates, and what the last 20 years of research has shown from Eric Westman onward, is that diets that are absent carbohydrates are healthy diets. That's what we've learned. So you can pull the drug lever or you could pull the diet lever, and if you pull the drug lever, okay, technically I'm out of time, but I'm going to take another 2 minutes. Let's get rid of this ugly slide. This is my fantasy. This is what, imagine patients being treated, and I'm going to say this on the panel, but I'll say it now. So a patient gets diagnosed with type 2 diabetes. Type 1 is insulin dependent, so we're going to leave that out right now. They get diagnosed with type 2 diabetes, and you say to them, we have 2 levers we can pull. You have drugs and you have diet. And you can do them both. If we put you on drugs, and we can do that. We have great drugs, and we have better drugs every year, and there are new drugs coming down the pipeline. These drugs, you're going to lose weight, you're going to have, great, we're going to keep your blood sugar under control. There are all these complications that are going to happen. They might happen anyway. Okay, so you may go blind, you may have nerve damage, and you might have some of your limbs amputated, and you may die 5, 7 years earlier than otherwise. But the drugs will be great, and you could eat anything you want. Or you could eat this diet, and you'll be fine. Your choice. Thank you.
Oh, Gary, stay. We would go into questions, and there have been some a few interesting questions that perhaps those that have posted questions on the app can pose it to Gary in the breaks. Just from the bottom of my heart and from everyone at PhD and everyone here today, just thank you so much for all of the work that you've done over the years since your very first article in the New York Times in 2002. Well, it's all been a big fat lie. And, the preceding books after that, Good Calories, Bad Calories, Why We Get Fat, it's just been so influential for all of us. And kind of that being said, we'd like to give you a Lifetime Achievement Award as a result. And to present that award is an explorer, adventurer, entrepreneur, and philanthropist, and primary patron of the PHC, Mr. Steve Bennett. So, Steve, if you want to come on up.
Thank you.
Gary, quite loud. Sorry about that. Do you mind if we call it the Unwin area?
Yes.
Shall we?
I would go for the Hallberg era.
Oh, well, this side of the Atlantic, we'll call it the Unwin era. How about that? Is that okay? Compromise. Yes. Thank you, David. Your books have inspired us all, and Sam and I were talking about who to make an award to this year. It was David last year, and we thought that this year, all the work you've been doing, and especially with the new book and the research that's gone into this, it struck a chord with Sam and myself and the rest of the team. So we'd like to award you a small trophy for all the great work you've done. Thank you very much.
Love this. Thank you, Steve. Thank you.